Welcome to Seattle. Welcome to the Oishi Symposium. Welcome to SWOG 2022 Spring. Love to see you all. It's good to be here together. We're going to go ahead and get started because we have a very full, action-packed, adventure-filled, jammed agenda for this symposium. We're so glad to have time to be together. I want to welcome all of you in honor of Dr. Oishi. He was a great supporter. We were just reminiscing about that a little bit, how much we miss him. He and his wife, Jeri, have been supporters of our oncology research professionals team for a very long time, and this symposium was named after him in appreciation and gratitude for their support. We have a number of announcements today we're going to quickly go through together. All the information will also be found in slides that will be posted in a couple of weeks. If you miss something critical, you can flag any of us down, or you can also just wait for the slides. Some logistical details. Questions can be submitted via the chat. We're going to try to record the questions so that if there's breaking news that comes out there instead of in the slides, we'll try to post that as well. There are no formal CE credits for this meeting, so do print a copy of the agenda. There's a place that you can fill it in yourself and indicate how much time you spent here and save that for your personal file for CE credits. Please do mute your phone and your computer to help with sound. We want to tell you about ORP a little bit. All of you are members of ORP. If you're here at SWOG and you're a SWOG member, ORP stands for Oncology Research Professionals. And SWOG, this is a quote from leadership, the recognition that we play a crucial role in the successful development, implementation, and analysis of any SWOG clinical trial. There are a number of ways you can get involved beyond attending meetings, and if you'd like to know more about that, there's some information on the website and an application on the CRA workbench to join our committee at a more deeply involved level. We are here to serve all of you. It's not the other way around. So we do have some committee structure. We wanted to share with you some of the committees, the working groups that operate to help bring you education and promote integrity and excellence in clinical research. We have our executive committee, and I'll share those names with you in a second. And I'm happy to tell you that Dana Little hasn't given up on me yet. She's our co-chair with our vice chair with us for this committee. And then also we have our nursing research committee led by Jamie Myers, our ORP liaison committee. And I know a few of you may have tried to find that meeting yesterday, and I apologize that it was canceled at relatively the last minute, but there is a virtual meeting planned next month. So if you're looking for the ORP liaison committee, I would encourage you to email Seal and Sandy, and I can get you their emails if you don't have them. But they're planning a virtual meeting in about a month. The membership committee co-chairs are Anthony Hicks and Lisa Stopenhagen. Anthony's here today. Anthony, raise your hand. And then education, I'm very proud to announce our two co-chairs who have just stepped up really on a moment's notice and helped with so many big things in putting all of these sessions together. Deb Bergevin and Joyce Tull, who are both here today. Deb and Joyce, raise your hands. And then our site operations committee, I work on that together with Liz Edwards and Caitlin Hutchinson. I'm grateful for Liz, who's in the back of the room. I think I saw her way in the back. Thank you, Liz. We're all here to help you and serve you. So if you need anything, feel free to stop any of us throughout the meeting and let us know what you're thinking. This is the executive committee for the ORP. Many of the names I just mentioned and a few besides. Just want to call your attention to ORP liaisons because a number of people do step into this role, which is a way you can get more deeply involved in sharing boots on the ground frontline experience, helping with protocol development, helping recommend tools, being an active communicator with SWOG protocol coordinators, and giving feedback, real-time feedback about what goes on in the real world in the field, reviewing chapters for things that are written and helping to mentor and support. It's a really fun role. You can be as involved as you want, but generally it could take you up to maybe a half hour to an hour, a month, a week. Depends on the protocol committee you're on, but there are some openings right now. Breast committee, symptom control, early therapeutics, GI, leukemia, lymphoma, and myeloma do have some openings for liaison positions. You'll notice Seal's email and Sandy's email, but also if you go to the ORP website on SWOG, there's an application that has all of our ways to reach us if you're interested in applying. You're going to hear more today from Kara Laubach, who's helping us with clinical research resources. And we're really excited about the way SWOG is organizing all of these things in one place for us to find. The workbench is your go-to resource for so many things. Just wanted to highlight that, and you'll hear more about that today in open forum. Some reminders, if you don't know what to do, ask. SDMC has listed contacts on the CRA workbench, and so I know sometimes we're all very good at what we do, and we tend to think it's a badge of weakness if we ask for help, and it's the exact opposite of that, really. The more you're in communication with our folks at SDMC and others, the tighter our data is run and the better our outcomes. So don't hesitate to ask. SWOG is very, very open to that. Do please mark your calendars to join us in October, downtown Chicago. Plan on attending open forum following this after lunch. And then Friday, there's a special symposium for oncology advanced practice providers. So please be sure to check that out as well. We can't go by without thanking the Hope Foundation. They have provided us with some travel scholarships. Some of you are here because of the funding that Hope Foundation provided us. Our breakfast is compliments of them, and they've done so much to keep us going and moving through all of this. This is a pretty extensive list, but these are some of the hands who came together and did the heavy lift for this symposium. Our speakers are here, our education work group members and others. So I want to thank all of the folks on this list and turn this over without further ado to our co-chair for the Education Committee, Joyce Toll, who's going to take us through the agenda and help us go forward today in this very exciting meeting. Thanks.
Thanks, Connie. And let me take a moment on behalf of all of us to thank Connie for her endless leadership as the chair of the ORP committee. She acts to represent all of us when meeting with the board, when talking to the leaders of SWOG. And I think her voice has been one of the most instrumental and powerful voices for all of us. We know that we're the boots on the ground that get it done every single day, and that without us, the job would not be completed. And so she has been just a phenomenal champion of all of us. So I want to say thank you. A little bit about the agenda. We're going to try and run on time. We've already started just slightly late, so we're going to keep moving right along. I have the honor of just moderating this, and the first person that I'm going to ask to step up to the podium is Maggie So. Maggie is going to be moderating this particular first presentation on coordinating research, and there'll be perspectives from both a consortium as well as a community hospital. So all of our different areas that we represent will be taken into consideration with this. So Maggie, if you'd like to join me.
Hi, good morning. My name is Maggie So, and I'm the NCTM program manager over at Fred Hutch right here in Seattle. And I'm also one of the members of the ORP education subcommittee. And it's just so wonderful to see so many of you join us this morning for our first in-person hybrid SWOG meeting. So I'm very delighted to introduce the first group of presenters who will be sharing with us their perspective coordinating RESIST from an academic consortium site, and also provide us some educational foundations on tumor disease response criteria. I would like to welcome the University of Washington's Encore Tumor Imaging Metrics core team. And today we are thrilled to have 4 imaging analysts from that team to speak: Danielle Cox, Shannon Morrissey, Dana Mill, and Chua Wang. Also want to let everyone know we will have time at the end of the second perspective from the community side immediately following this presentation for some Q&A. So without further ado, let me introduce you all first to Dana Mill from Encore, who will start off this presentation. So Dana, please take it away.
Okay, thank you so much, Maggie. Good morning, everyone, and thank you for joining us today for the Encore Tumor Response and Disease Evaluation presentation. Yeah, there we go. We can switch to our slides. Okay, next slide, please. Okay, there we go. Okay. Alrighty, so good morning, everyone, and thank you for joining us today for the Encore Tumor Response and Disease Evaluation presentation. Before we dive into our presentation, let me just briefly introduce myself and the Encore team. Next slide, please. My name is Dana Mel, and I am one of the 4 research coordinators with Encore. Some of you might have already had the pleasure of working with a couple of our research coordinators, Danielle Cox and Shannon Morrissey. Danielle has been with Encore since 2019, and she's also the clinical lead and research scientist. Shannon Morrissey joined the team in 2020. She's also the lead research coordinator and also the research coordinator. Shuo Wang and myself, we are also research coordinators, and we both joined the Encore in January of this year. Janet Busey is the Assistant Director of Research, and she also oversees our team. And our team would not be complete without a group of radiologists that we work very closely with. They have different specialties in body, neuro and musculoskeletal radiology, and cardiothoracic radiology. Next slide, please. Now, let me give you a quick overview of our presentation. So we will start with the mission and values of the Encore team, followed by precision imaging metrics, which we also call PIM. This is the software that we use to evaluate cases. We will look at some Encore key metrics and different criteria we use to evaluate cases. This will be followed by the evolution of RESIST criteria, and we will look at the actual cases workflow and how we process cases. We will discuss the benefits and impact on patients, and then we will give you an overview of the RESIST 1.1 baseline and what a follow-up assessment looks like, along with some case examples and their different responses. Lastly, we will give you a quick overview of the Encore research and finish with the summary of our presentation. Next slide, please.
Thank you, Dana. So first, I will introduce the mission and values for our Encore team. Our Encore as a team of highly skilled image analysis and professional radiologists. We use imaging and imaging-based criteria provides high quality, accurate, precise, criteria-based imaging assessment of tumor response for patients on oncology clinical trials. So we are able to get therapeutic decisions for improved patient outcomes. And we also provide additional activities to support the research mission of the institution. Next, please. So before 2014, we track the metric data on paper by hand. Then we move into the PIM software, which is known by Precision Imaging Matrix. It is developed by our collaborators at Dana-Farber and Howard Cancer Center. It helped us to organize patients and trials, as well as provides an interface for both processing cases and retrieving data. Next, please. So by using the PIM software, we are able to deal with increasing number of criteria for many types of cancers, and we are able to process cases, manage clinical trials using a cloud-based system. Next, please.
And here are some key metrics for our center. Currently, we have over 750 active clinical trials. We've historically completed over 25,000 scans, and we currently evaluate using over 25 different complex criteria. On the left, you can see a list of some of the most common criteria we assess by, and in the graph, you can see that RESIST 1.1 criteria by far makes up a majority of the cases we process, followed by Lugano, and then PCWG2 and 3 criteria, as long as IWCLL. New criteria are being developed all the time, and anytime a new criteria is developed, we do our best to add it to our repertoire and expertise. Next slide, please.
Okay, so just to go into a little bit further detail of what Shannon was saying on the previous slide, listed here are some of our commonly assessed criteria and also some examples of the different modalities we may be evaluating. So when is each of these criteria used? That can definitely be dependent on the specific protocol, but generally RESIST 1.1 is used to evaluate solid tumors in a variety of different cancer types and therapies. We also have some immune-related criteria listed here, such as iResist and IR-resist. These are used for patients on immunotherapy drugs. Also, we have our lymphoma criteria, such as Chesson, Lugano, and Lyric. These are used to assess lymphomas, and they also incorporate the use of nuclear medicine PET scans into the assessment. We also use commonly IWCLL criteria, which is used specifically for leukemia patients. And lastly listed here, we have our PCWG criteria, which is used for metastatic prostate cancer patients, in which we incorporate the use of bone scans into our assessment as well. Next slide, please.
So as the drugs and the treatments change over time, so the criteria have evolved. So here is an example showing the evolution of the RECIST criteria. So first in 1979, the World Health Organization published the first tumor response criteria as a standard for assessing treatment response. And later in 2000, two more organizations as the National Cancer Institute and the European Organizations for Research and Treatment of Cancer, these three proposed the new RECIST criteria. And later in 2009, the RECIST working group revised the original criteria with a new version of RECIST 1.1 to address a number of questions and issues have arisen since the introduction of original RECIST criteria, including the assessment of lymph nodes and the use of neuroimaging technologies such as multi-detector CT and MRI imaging. And you can also see there are branch of variations of RECIST. These variations are developed to evaluate tumor response for different immunotherapies, as well as adapt neuroimaging modalities. Next, please.
And this is our typical workflow. We do about 20 plus cases a day. Each takes about 1 to 2 hours to complete. Once an order is placed by trial staff, it is reviewed by the Encore team to ensure we have the reports and images available in packs. If there is information missing, we reach out to trial staff. Once the order is complete, the case is then evaluated by Encore team and an overall response is determined. Then the case is reviewed by one of our radiologists. And once the radiologist finalizes the case, the study team gets notified. The case is then reviewed by the PI or oncologist. And if there is additional clinical information they need, they reach out to our team for reanalysis. If no further information is needed, the treatment decision for the patient is made based on the overall response. Next slide, please.
So our response criteria assessments here in Encore help answer the question, is the patient's treatment working? So we provide clinicians with concrete data to make care-related decisions utilizing precise measurements and image data. This gives direct feedback to patients and sponsors on how their therapies are working, and also promotes communication and partnership among study teams, PIs, and oncologists. So one of our main goals in Encore is to help facilitate the determination of the efficacy of experimental cancer treatments, which ultimately improves patient survival and well-being. Next slide, please.
So for the next few slides, we'll do a quick overview of RECIST 1.1 criteria, which, as mentioned before, makes up over 50% of the cases we process. So RECIST 1.1 has specific baseline criteria, which defines which lesions can be considered a measurable target lesion and which will be tracked qualitatively as a non-target lesion. On the right, you can see a typical baseline order where we have 4 measured targets. There are minimum size requirements for target lesions, and the criteria states we can follow a maximum of 5 target lesions with a maximum of 2 lesions per organ. In addition to target lesions, we assess non-target lesions, which are any sites of non-measurable disease and are qualitatively assessed. These lesions are measurable lesions which exceed the number of lesions allowed per organ, or are truly non-measurable disease like ascites, pleural effusion, or blastic osseous lesions. Could you click, please? Thank you. Once we have our target lesions measured, these are summed together to quantify the sum of diameters, which will be used as our baseline tumor burden for us to compare future follow-up measurements to. Next slide, please. In this table, you can see a breakdown of the RESIST 1.1 overall response criteria. As you can see in the leftmost column, we utilize the change in the sum of diameters of the targets, the qualitative response of the non-target lesions, and we also assess if there is any new disease in the patient to calculate an overall response. For progressive disease in red, we would see at least a 20% increase in the sum of diameters of the targets, or unequivocal increase in any of the non-target lesions. Any new lesions found in the patient would also warrant progression. For partial response in teal there, we would see at least 30% decrease in the sum of diameters compared to the baseline. For complete response in green, we are looking for complete resolution of all target and non-target lesions. And then for stable disease, the time point would not fit any of the previously described responses, as there would be no significant change in the patient since the previous time point. Next slide, please. Here you can see an example of the RESIST 1.1 criteria baseline we were looking at before, and the first follow-up for a patient. And together we'll do a quick example response assessment for the second follow-up. Click, please. As you can see, we have already measured the targets and identified the non-targets. So we're going to focus on the percent change listed below the measurements. These 3 percentages are calculated from summing up those target diameters above, and they represent the percent change seen from the baseline time point at the top. The next is the nadir time point, which is the time point with the best overall response so far. And then below that is the prior time point, which in this case is also the nadir time point. As you can see, there's been a decrease in 55% since the baseline. Click, please. So what would our overall response be? Does anyone want to try to guess in the chat if they remember? A decrease in 55% is an overall response of? Anyone want to take a guess? Yes, exactly. Julie got it. It's PR. So click, please. Yeah, partial response. And one more click, please. So we were looking at that negative 55% specifically. So thank you, Julie. And next slide.
Okay, so we also wanted to show you the differences in response you could see depending on the specific criteria used. So here you can see the patient has a new splenic lesion on their first follow-up imaging, which is added as a new non-target site of disease and automatically causes progression using RESIST 1.1 criteria. Next slide, please. But if you look at the same patient with the same scans and assess using one of our immune-related response criteria, IR RESIST 1.1, you can see using IR RESIST, new lesions are measured and added as new target sites of disease, which factor into the total tumor burden calculation and do not necessarily cause overall progressive disease. This can allow patients on immunotherapy drugs to stay on trial longer and continue therapy as they might be showing pseudoprogression. Pseudoprogression is the appearance of new lesions or an initial increase in tumor size followed by a decrease in tumor burden, which is often seen in patients on immunotherapy type drugs. Next slide, please. Okay. In addition to our standard tumor metrics criteria, our Encore team is also involved in a number of internal research projects related to response criteria, such as the ones listed here. Next slide, please.
So in summary, we talked today about the Encore team that we provide high quality, accurate criteria-based imaging assessments of tumor response for patients on oncology clinical trials. We work closely with radiology study teams, principal investigators, and oncologists. We also went over overview of Encore's case workflow and process from placing an order by trial staff to treatment decision. We also did a quick overview of different criteria we use, including our most common criteria, which is the RESIST 1.1. We also provide clinicians with concrete data to make care-related decisions and give feedback to patients and sponsors on how therapies are working. We are also involved in research. Next slide, please. So we wanted to thank you all for joining us today. We really hope that you enjoyed our presentation. And if anyone would like more information about Encore later on or has any questions, please feel free to contact us at encore@uw.edu. Thank you, everyone. Next slide, please.
Great. Thank you so very much, Team Encore, for that wonderful presentation. So we're going to go ahead and segue to the next presentation. I'm going to pass it to my other colleague on the committee, Jessica Hines, to introduce the speakers for the community hospital perspective. Jessica?
Hello, good morning, everyone. I'm Jessica Hines. I am a research coordinator at SCORE Encore, and I'm also on the ORP Education Subcommittee. I have the pleasure today of introducing Pam Mason and Julie Williams from one of our sites, First Health of the Carolinas in Pinehurst, North Carolina. They are a group of experienced people, and they are very knowledgeable. So today they will be talking about how to coordinate Resist 1.1 from a community perspective. Take it away, Julie and Pam.
Hi, everyone, and welcome from Pinehurst, North Carolina, the golf capital of the world. Thank you for inviting us today. Next slide, please. We wanted to share our perspective from approaching RECIST and image tracking on a community site level. We're going to talk about what we do to set up our site for success as the study coordinator and the tracking tool that we use. Next slide, please. First thing we want to do is utilize the same reading radiologist. It's optimal if you can do that, or at least have a core group of radiologists that can read your scans. Our site has about 20 radiologists that are reading at any given time. You're not always going to get that same person. We try as best we can so that you have that consistency from scan to scan. The next thing we want to do is look at your screening scan. And can you use the standard of care scan that was already done versus does it have to be study specific after the patient has signed the consent? Some protocols will allow you to do a standard of care scan if it was done within a specific time range prior to the patient going on study. Always refer to the protocol and any notes or trainings such as SIV presentations for study-specific guidelines regarding whether the allowed timing for standard of care imaging can be used if it's already performed, or if this is acceptable to use for baseline and screening requirements. If the scan was standard of care, please have the radiologist read the scan to obtain measurements based on the identified lesions. If it was a standard of care scan, they're not going to have that information and that terminology in that report that you've already received. So they can do a reread at that point. Remember to save any correspondence that you have received from them regarding approval from sponsors or the CROs for your approval to be able to use that scan. Keep it in your source. It could be years down the road before someone asks for that. You may not be the coordinator that's still on site at that time, and it'll be useful for other people that follow. Identify the baseline lesions. You always want to look at the lesions that are measurable, if they can be reproducible on subsequent scans. Refer to those lesions with the treating physician. Include the lesions on a tracking tool, whatever your tool may be, for comparison at subsequent time points. Refer to the protocol-specific guidelines regarding use of lesions noted with prior radiation, whether or not they were in a surgical field or if the area has been biopsied. If any of those cases have happened, then they could be used as non-target lesions. Communicate the target information to your radiologist ahead of time. So what the location and image slice from previous scan, if you have that in the report. Request lesions to be measured in 2 dimensions. That is not always going to be recorded in the report and documented if you don't request it. Then you'll have to go back to the radiologist later and ask for 2-dimensional measurements, especially when it comes to a lymph node. That's very important because you're going to use the short axis on the lymph node rather than the long axis. How we communicate with them. So understand your facility. Who are your people that you're going to talk with? Identify somebody in that imaging department that you're going to have as a contact. So for us, that's the imaging coordinator in the imaging room that has access to the reading radiologist at all times. So we know who that person is. We use an email notification ahead of time. We also can use the secure chat option in our EMR. Our EMR is Epic. So there may be something in the EMR that you use that is also helpful to you, that you can get information to them. Our nurses or ourselves, whoever's putting in the order, can also put that information into the order in the EMR, so they're getting it in multiple locations or multiple sources so that it's not missed. The radiologists here appreciate having that up front rather than having to go back and add it or do an addendum on a report later. Next slide, please. Consider the timing of the scan. So what works best for the patient within the protocol parameters? It's always good practice to ask the patient, do you prefer mornings? Do you prefer afternoons? Not everybody is a morning person and they don't want to come for a scan at 7 o'clock in the morning or arrive at 7 o'clock in the morning. So before a visit, a few days prior works best. Avoid being able to do a scan on the morning that you have to have cycle 1, day 1 treatment, because you're going to want to have that information before you actually start, especially if you're randomizing on the day of cycle 1, day 1. This will provide you time to review the scan. You don't have to rush to be able to analyze it, get to the physician to review it with them. And remember that scans typically follow a set schedule regardless of a cycle delay. Want to be proactive. Check for scan results. Review with the treating physician. They may or may not be the primary PI, and they might not be as familiar with the process. Ask for clarifications or addendums from the radiologist. We have PIs who are also surgeons. They're not available to us every day. If the physician is someone who will actually pick up the phone and call radiology and say, hey, I've got this scan on here. Could you look at that and talk with me about it? The physicians that we work with a lot of times will actually open up the imaging system and review the scan with the radiologist. If they're not available to do that, then the study coordinator can do that. And you're that advocate for that patient. Be proactive about doing that. That's where that secure chat comes in handy for us, is to be able to contact that reading radiologist, and then they can get back to us so that we can get a clarification or an addendum can be done at that time. And a note on patient notifications. Now that we have laws in effect that results are populated out for patients to review in their EMRs or the EMR portal, patients may be able to see those results before we have actually had a chance to review them and do the tracking information. Then they might call you. You're in clinic seeing patients, so you might get phone calls or emails or MyChart notifications from patients that they're concerned about their scan. So it's helpful to alleviate those fears, have conversations with them up front. Remember, you're having your scan. That scan's going to be released. Even if we haven't had a chance to see it, and if you see something that's concerning, it's okay to leave us a message. Just make them aware that if there is something of concern, then they're going to be notified by us. As soon as that physician has seen it and they're aware of it, they reviewed it, then they're going to notify the patient. So alleviate those fears up front and let them know that someone will reach out to them. Know your resources, your protocols, your team members, physicians, anybody in your organization that you're going to be working with to make this a successful outcome for the patient, for you. And remember, it's always okay to ask questions. That's how we learn. Next slide, please.
Hey everybody, I'm Julie Williams. I'm going to walk you through the RECIST tracking tool that we use here at First Health. So the first thing to remember when you're using a tracking tool is to make sure that you customize your tool to the protocol. This is going to be your source document, so we need to make sure that it matches anything that needs to be captured in the EDC. For example, some protocols will use non-target definitions of present or absent, whereas others may say something like non-CR, non-PD. Always remember that when you have a new lesion, that can then be added to your tracker as it needs to be. Next slide, please. So this is the tracking tool that we use at First Health. It's an Excel file, which we're happy to share with anyone that would like to have it. Our email addresses are at the end of this presentation and will be posted, and the presentation will be posted. So make sure your tracking tool has the protocol information, and 2 identifiers. You'll need the date of the procedure, what type of procedure it was, so a CT of the chest or a PET scan, whatever your protocol requires. You'll want the lesion location, and we try to use the exact wording that we have in the radiology report so that there's no question about if you have to also upload the radiology report to the EDC, that they will match directly come audit time. You'll also want the measurement unit, so make sure you specify whether your measurements are in millimeters or centimeters. And then at the bottom of our tool here, we have just kind of a reminder to ourselves and to the treating physician about what the definition for the RECIST is for CR, PR, SD, and PD. And then we have a signature line for the treating physician, because we are going to print this out and have it actually signed by the physician. Next slide, please. So we really like this tool because it does the math for us. We really only need to put in the information for the lesion information. And then, so for example, on line 11, we have the right mediastinum, and I picked this is an actual patient. I picked her because it's kind of simple. We just have one lesion, but if you had multiple lesions that were target, you could add those in lines 12 and 13, and then the sum of those would be collected for you in line 14 or cell 14B. So you can add new lines if you need to, and then if you have more than 3 or 4 target lesions. Next slide, please. So this is just a slide to make sure you understand the calculation, and the first group sort of went through that before, but on that line 16 is where our percent change will be. And our calculation is set up so that if it's a negative number, it'll be a decrease, and a positive number will be an increase. And as you're going to see on the next slide, please, this patient had a 0. So of course, we're still in stable disease for that first scan. Next slide, please. So, and the first group also mentioned the nadir, and we always have to remember the nadir, and sometimes I think it kind of slips our mind a little bit. But if you're having a patient who is having a response and their total longest diameter is decreasing, you have to make sure you include the nadir. So here we have on line 18 and cell 18D, the equation where we are considering the nadir from the scan on 7/23/21, which is 1.4 centimeters, and comparing that scan from 9/3/2021, which was 1.6 centimeters. And we're doing that same calculation where we're looking for the difference between the two and getting a percentage, where in this case, it's again, a positive number is going to be an increase and a negative number will be a decrease. Next slide, please. The other thing to remember is that you might end up with new naders because the nadir is the smallest value. So as your patient moves through treatment, your nadir could change. Next slide, please. So I hope you can understand the tracking tool that we use. You can always add in a new line for a new lesion. And we have found in our experience these two articles, which are freely available to you, to really help solidify what's going on with RECIST 1.1. And we refer to them quite often, especially when there are things that we haven't even touched on today, like what happens when lesions merge, or when you have one lesion that becomes two different lesions. That can get really complicated. And these two articles are helpful for kind of teasing that out. The SWOG also has a tracking tool and RECIST information on their website, which is listed here. And we're both available for contact if you would like to reach out to us. But the number one thing to remember is try to set yourself up for success, and using a tracking tool does that. Our situation at our institution may not be what works for you, but finding a contact in the radiology department is really, really helpful. We had a contact and she moved and we didn't know it, and that made our whole process break down a lot. But keeping that open communication, asking questions, involving the treating physician as much as they're willing to participate, hopefully a lot, but sometimes it's harder and you have to work with the radiologist instead. So yeah, thank you very much for your attention. And I think it's time for questions for us or for the Encore team. I guess next slide. I'm not really sure what's coming next. Oh, and there's a question in the chat. I guess I can try. If a patient has a partial response of minus 35% and then a next scan has a minus 28% as the overall response, is it still partial or should it be changed to stable? Well, I think the other thing to consider here is the nadir. So again, understanding the math here is important. The nadir possibly has now made your patient actually have a progressive disease. It depends on the numbers. But a stable scan, a 28% decrease is stable. The volumes at our site, we are much, much, much smaller than Encore. We probably have about 30 open studies at a time. That's like accruing. So we're only talking about probably maximum 15 patients that we're tracking RECIST for. So it's much, much smaller.
So I want to pause for a minute and thank
Sure.
all of our speakers from this morning. There is a question from the floor.
Thank you, Julie and Pam and the Encore. I really enjoyed the presentation. This question is for Julie or Pam. When you use your spreadsheet and have the investigator sign, do you print it out at each time point and have them sign and date at each time point, or once the whole thing's complete? Thank you.
Yeah, that's a great question. We do have that, we print it at each time point. And in fact, we also then scan that and upload it into our EMR so that it's accessible for remote monitoring if needed. But yeah, each time point. And, we didn't touch on this either, but it has happened that a new radiologist will read a scan and find a lesion that the previous 3 did not. So that requires you to adjust your RECIST and go back and update everything. And that Excel file allows us to do that too, sort of easily, I guess. And remember, if that does happen,
Tasha, are there other questions?
in your EDC.
Thanks. Are there any other questions from the floor? Okay, thank you again to all of our presenters that helped pull this together. Deb Bergevin and I adapted the education committee sort of on the fly, and Deb was instrumental in helping pull all these people together at her site and a few others. So I want to say thank you very much for that also. Why don't you take a 10-minute stretch break, go get some fresh coffee, and we'll see you back at 9 o'clock, a little bit after probably. Okay, take care. There are 3 key test sites. Keith is presenting to the Board of Governors today. NCARTS is a tool to put data that's in Epic and auto-load it into a SWOG-based system. So I'm wondering if we could talk about some of those kinds of things. We could grab QA into it in terms of the change between monitoring and auditing. Just a thought. We can talk more about it. Well, so many of the people have Epic. And the feed is going well. They're going to ask to expand it and get more sites involved. So depending on how that Board of Governors presentation goes, it might be a lot of fun. And I just happen to know the person who's running the sites. It's 3 beta test sites, but if it goes well, they'll start expanding. It's called NCARTS, and so many people have Epic. It merges with Epic, and the Epic Good morning, everyone. We're going to get back in session. One of the protocols that we have faced, probably one of the most daunting challenges with, is S1826. And it has been a variety of challenges, both notified of this from the Statistical Center and a variety of other places. So we thought it would be good to focus on a protocol that does need disease response assessment. We are very fortunate to have two specialists with us. They're remote. Dr. Costa Shields is going to speak on the protocol itself. And then Iris Kat Sequa, and I apologize, Kat, if I mispronounced your last name, is going to present some very basic, the nuts and bolts, what I call the nuts and bolts of how to get the job done. So if I can turn that over to Dr. Shields.
Thank you so much, everybody. I hope you hear me well. Okay, so if I can have the next, yeah, this is fine. This is a phase 3 randomized study of nivolumab plus AVD or brontaximab vedotin plus AVD in patients with newly diagnosed advanced stage classical Hodgkin lymphoma. Briefly, as you all know, nivolumab is a targeted therapy using human programmed death receptor 1, PD-1, blocking antibody administered intravenously. While brontaximab vedotin or BV is a CD30 directed antibody drug conjugate ADC, meaning that it consists of a monoclonal antibody and an anti-neoplastic chemotherapy agent. Next slide, please. This study is an intergroup trial run by the North American Hodgkin Lymphoma Intergroup with participation of NCI-sponsored collaborative groups, including Alliance, ICAG, Akron, SWOG, Canadian Cancer Trials Group, and COG. Next slide, please. So this trial is enrolling patients who are 12 years and older with untreated newly diagnosed stage 3 or 4 classical Hodgkin lymphoma. And the sample size is 987 patients with a target enrollment rate of 20-21 patients per month. Projected accrual time is 4 years. And it's a little crowded. Just look at the schema on the right, the slide. So patients are randomized to 1-to-1 to receive 6 cycles of treatment with either Nivo AVD, chemo as shown in arm 1 of the schema, or BV AVD as you see in arm 2. Patients are eligible to receive radiation treatment to FDG avid, PET positive, in other words, tumor areas on the end of the treatment PET scan done 4 to 8 weeks after cycle 6 at the discretion of the treating investigator. Primary endpoint will compare the progression-free survival in this group of advanced stage classical Hodgkin's lymphoma patients randomized to receive either an AVD versus BV-AVD. So key secondary endpoints include overall survival, event-free survival, the end of treatment complete metabolic response rate, safety, tolerability, so one drug compared to the other. Another key secondary endpoint will compare patient-reported symptoms, health-related quality of life between the study arms. Next slide, please. So currently the study is NCTN-wide active in the US for adult and pediatric patients. 741 of the 987 patients were recruited to the study as of the end of February 2022. 440 sites were approved, and number of NCI community oncology research program approved to enroll is 196. Next slide, please. So as a summary, this study represents an effort to improve the cure rate in advanced stage Hodgkin's lymphoma and to harmonize treatment approaches across pediatric and adult patients. Mainly, this study evaluates nivolumab, a drug that is highly effective against the disease and well tolerated as part of frontline therapy for advanced stage HL. Historically, the approach to treatment of advanced stage Hodgkin's in pediatric patients has incorporated radiation treatment in a high proportion of patients. So the goal is to reserve radiation treatment for patients who are most likely to benefit and minimize radiation use in the youngest patients at highest risk for secondary complications. So only those patients with residual PET findings receive RT in this trial. The criteria for this include Deauville score 4 or 5, that is the PET positive group after treatment, more than or equal to 30% reduction in maximum transverse diameter, and residual lymph nodes greater than or equal to 2.5 centimeter, or extranodal site greater than 1 centimeter. Next slide, please. So for the response assessment, PET-CT scans at baseline and 4 to 8 weeks after last dose of study drug are required. And for the RT patients undergoing radiation, PET-CT after RT is required. Response assessment will be done locally according to the Lugano classification. Therapy is not intended to be PET adapted. Alteration of the NAVD based on interim PET in the absence of a other progressive disease feature or biopsy confirmation is a protocol violation. Interim PET is not required per protocol, except in those patients who are declared for the intent to use residual PET RT. So only undergoing RT, but this should be declared at the beginning of the treatment. As for the end of treatment response assessment, due to challenges in interpreting PET-CTs in Hodgkin's lymphoma patients treated with nivolumab, it is strongly recommended that patients undergo biopsy to confirm residual Hodgkin's lymphoma prior to initiation of a second-line therapy for suspected relapse or refractory Hodgkin's lymphoma. So for indeterminate PET results in the absence of biopsy, repeat imaging should be performed after 12 weeks or sooner to confirm progressive disease. Next slide, please. I'm just, probably you know all this, but emphasizing what Deauville is about here, criteria, which is part of Lugano response classification. So basically this slide summarizes the criteria as a positive and a negative PET result description. Briefly, any uptake at tumor sites that is moderately or significantly above the liver background uptake is considered a positive result. Suggestive of residual tumor. Next slide, please. Here's a case example to make you a little more familiar with what we're facing as imagers. This is a patient with a large axillary lymph node at baseline and with significant uptake, FDG uptake in the axillary lymph node, denoted by arrows here. During or after treatment, this is happened to be a during treatment evaluation. The lymph node shrinks significantly with decreased uptake, but there's still persistent uptake in the lymph node. And if you compare that with the liver uptake, as in the far right of the slide, the liver slice, it really corresponds to a liver score 3, meaning uptake is at the level of the liver uptake. So that is a complete metabolic response and a negative finding. Next slide, please. Regarding the study evaluations, all patients registered to this study will undergo retrospective pathology review. Again, all patients are planned to undergo retrospective PET-CT review. For patients declared for residual PET-RT at time of registration, IROC Rhode Island will verify that the patient meets protocol specified RT criteria and will confirm eligibility for RT with the treating investigator, or notify the investigator in the event that the patient does not meet the protocol specified criteria for RT. Next slide, please. So required imaging submission, PET images must be locally read and interpreted by the local site radiologist. PET-CT must then be submitted to the Imaging and Radiation Oncology Core at IROC, Ohio. If PET-CT is contraindicated for the patient, sites are to submit the contrast-enhanced CT, MR, or MR-PET from the same time point. But hopefully this happens rarely. Digital image submission is required for collection and submission at the time points of baseline. That means performed within 42 days prior to registration, and must be submitted to IROC within 15 days after registration. Interim PET scans that are performed for clinical purposes after day 15 and prior to cycle 3 must be submitted to IROC, again within 15 days after assessment. End of treatment performed 48 weeks after the last dose of the study drug must be submitted to IROC, again within 15 days after assessment. Progression, relapse, PET-CT scans, if performed, must be performed, must be submitted to IROC within 15 days after progression or relapse. So that's, I believe, I guess that's it for my part. I will stop here.
Hi, good morning, everyone. My name is Iris, also known as Kat, and I am one of the DC for S1826. I am here to talk about the data submission guideline, but I'll mostly concentrate on the most common mistake that we see when we're reviewing charts for this study. Next slide, please. So the 1826 data submission guideline can be found by going through the SWOG CRA workbench and clicking the ORP manual, chapter 16G. It's right there. There is also a link to the document on CTSU under the protocol related documents tab. Next, please. The data submission guidelines were written to clarify form instructions, not to replace them. They address common errors and FAQs. As you can see, they cover many topics, but today we will focus on, again, the most common errors we see. Next slide, please. So we will start with the open registration we see a lot of mistake on here. So we figured we'll start from here. Next slide. So the most common one is the IPS score. The IPS score is the number of yes above, like, if age, or for example, on this one, male is yes, and that's the only yes, and the IPS score below should also be one yes, and the international prognostic score should be 0 to 3. So just make sure that everything matches up. Again, IPS score totals the number of how many yeses are there. Next slide, please. The next one we will talk about is the vital status form. And there are two different types of vital status form, the on treatment and off treatment. Next slide. First, we will talk about the on treatment vital status form. So please make sure to fill out this form before you fill out any of the treatment form or the AE form, because if you don't fill out this form first, you are going to get a lot of like pinkies on your treatment form and AE form. It can cause a lot of issue. Also, I know the instruction on this form, it says that please fill out this form every time you make contact with a patient. It's not exactly true. You don't have to fill this out every time you see the patient, you bump into them in the pharmacy. It's not really like that. Technically, for on treatment, while patient is on treatment, I should only see 7 forms on here. Day 1, from cycles 1 to cycle 6, day 15, or end of treatment. So there really should not be more than 7 vital status form. But the instruction on how often this should be filled out is on section 14. So make sure to just look through section 14. Next, please. And this is the vital status of treatment form. And again, on this one, you want to fill out the off-treatment vital status form first before you fill out the follow-up form. It's always in that way because whatever date is on the vital status form, the most recent date on here will automatically populate on the follow-up form. So let us say you miss 3 different time points. Let's say like March 2020, October 2020, and then December 2020. Make sure you fill out the vital status form first for the latest date, like March 2020, then follow up form March 2020, then move on to October 2020 vital status form, then follow up form. Make sure again, vital status form, follow up form first. Again, follow-up form will always inherit the date on the vital status form of treatment. Next slide, please. So now we'll go on to like the tumor assessment form. I'm sorry, I kind of messed up with my, okay. The tumor assessment form, I'm sorry. Next, please. First, we're gonna talk about the baseline tumor assessment form. This is the measurable lesion disease assessment form. As per section 5, patient must have bidimensional disease and the longest dimension of at least 1.5 centimeter for lesions to be considered measurable disease. So let's say if your patient has 0.9 by 0.8, I get it, you can measure it, but per section 5, that's not measurable disease. So that should be reported on the non-measurable disease form. The preferred method of assessment is PET-CT. So if patient had PET-CT and a CT, then method of assessment should be reported as PET-CT. And you can always add a note on the comment section of the form to report that, that the measurement reported on the form is from CT. PET status cannot be not applicable. This has to be negative or positive. If method of assessment is PET, PET-CT, or MR-PET, then this should be negative or positive. Again, if patient only had CT, then this should be not imaged by PET. SUB map should also be filled out. Or if it was not included in the report, then please request this form, you request this from the radiologist or treating MD. If this was not assessed, then leave the section blank and make a note on the comment section of the form why this is not filled out. Again, every time like you leave something blank, the comment section of the form is a good spot for you to let us know why is that. Next slide, please. So this is the non-measurable disease assessment form. The most question we get about this form is what is extent? Extent is just really the size or the measurement of the lesion. You know, this can be the actual measurement of the site, or you can just put multiple, extensive, localized, etc. Just don't leave it blank. Next slide, please. Okay, I hope I can pronounce this properly. The overall Deauville score is required for patients who had PET-CT. Please ask the radiologist or your treating physician to provide this information. Definitions for the Deauville score can be found in Protocol Section 10 or by clicking on the question mark icon in RAVE. Like the question mark icon at the end is very, very helpful. So make sure you always click on it if there is one. Hi, Rachel. Is there a PI around who can answer this one for me? I have to look at the protocol for this one. Okay. Okay, moving forward. This is the follow-up tumor assessment. So the new lesion section, please, please, please do not fill out this section. Filling out this section means patient has progressed. So if the patient had a new lesion, but the lesion is only suspicious but not confirmed lymphoma, then you should only leave a note on the comment section that's saying like, hey, we have this new site, but it's not, it's only suspicious, not lymphoma. The only time you fill out the new lesion section if it's a confirmed progression. So leave it alone, because every time you fill that out, it causes all these other things to populate on the background, like, expectations for progressions and whatnot. So let's not fill that out. Next slide, please. Okay, so all lesions that were reported on the baseline tumor assessment form must be reported on the follow-up tumor assessment form in this exact order. So all of the, again, all sites reported during baseline should also be the ones reported during follow-up. For each disease site, you must enter method of assessment, assessment date, PET-CT, SUV max, if assessed by PET, enter tumor measurements if obtainable. If tumor measurements were not obtainable, you must document the lesion number and reason measurement was not obtained in the comment section. Again, the comment section, every time you leave something blank, just put a note on the comment section so you kind of know what's going on. For the non-measurable lesion form, extent can is still the description of the disease. So just put like present, absent, progress, or again, the actual size of the site if it's there. Okay, next slide, please. Okay, now we're moving on to the treatment form. Thanks. Okay, so please carefully read the questions on the form before you answer yes or no. I think the first question on here is has the patient progressed? You all have no idea how many times you've seen that this is a yes. And again, this caused a lot of things on the background to populate, like, expectations for the progression specimen, and and then we're gonna get an email from you guys like a month later saying like the patient didn't progress, but not according to this form. So please carefully read the questions before answering yes or no. For the day 1 BSA and weight, this should always be filled out. you just remember that, you know, the treatment for this study, they are based on weight or BSA. So this should always be done. But let's say if the BSA for weight and the day 15 BSA weight, if you were unable to, you know, to collect this, it's fine. You can leave it blank and just leave a note on the comment section explaining why this was not done. So reporting period start and end dates. These are not the same as treatment start and date of last treatment. Reporting period is the length of the cycle. Reporting period start date is the day 1 of the cycle. And while reporting period end date is the day 1 of next cycle. Again, that information is on, if you click on that question mark icon at the end of reporting period start date, reporting period end date, it will explain it on there. So if you have forgotten what I said, just the question mark icon is your best friend. And then there's also the treatment start date is the day when patient first received treatment for this cycle. And the date of last treatment, of course, is when patient last received treatment for this cycle, including GCSF. Next slide, please. On the treatment section, dose planned at cycle start is the actual dose in milligram per meter squared or milligram per kilogram. So for example, the carbazine, this should be reported as 375 units, and units should be reported as milligram per meter squared dose. And then dose delivered should be reported the same as dose planned. The only time that however, if dose is held for day 15, then dose delivered should be reported as 0. And same thing is true if the dose for the carbazine is reduced. That should be the dose reported on for the dose delivered in the milligram per meter squared units. Total dose given is the actual dose that the patient received for entire cycle in milligram. Next slide, please. Okay, that concludes my presentation. If you have any questions, please feel free to contact us at lymphomaquestion@crop.org or call us at 206-652-2267. Thank you.
I want to say thank you to both of our presenters for helping to shed lots of light on S1826. Our next presenter, we're going to move right along because we're trying really hard to be respectful of your time and stay on our time agenda, is Kara Lawbuck. And Kara is the new training manager from SWOG, and we welcome you and we can look forward to hearing from you. And if I can ask our phenomenal IT team who is helping us with this hybrid meeting to move to the other slide deck, we're good to go.
Well, that's a way to start a presentation. All right. Glad that wasn't on video. All right, where's my confidence monitor? And that's why I was carrying my laptop, just in case. First of all, thank you all for making time for this presentation, for attending a group meeting. We are so excited to see you here. We are so appreciative of everything that you do. The main thing that I want to convey in terms of training responsibilities and our updates and our progress is that we are rolling out new training content as fast as possible. We are trying to provide you with resources and information to do your jobs. So we want our sites to be able to easily find information. If you have suggestions or information that you need, contact me at training@swog.org. Should be fairly easy to remember. So what we have
been rolling out. Hopefully you saw about the time of the fall group meeting. We rolled out some new resources on the website, and I have highlighted within this presentation to stay on time. I'm going to quickly just go through some things that I can't quite click on due to the the hybrid meeting, but the slides will be posted, and I hope you are able to go back and review those pages after the meeting. So there are all sorts of human subjects: research protection, OHRP, different resources posted online that are applicable to just about every clinical trial for new people that are onboarding and for people who have been here for 20 years, like myself, who, not here personally at SWOG, but within clinical research, who just need that one specific thing to be found, and there's searchable video resources that you can look at. The other thing that we just launched, is the resources for oncology research professionals, and there's some great data submission pages accessible from that. We have started with 1800D. We're going to be moving all of our new protocol-specific required training into the CTSU class system. And what this means is you no longer have to print a verification page and upload it to CTSU and wait 3 days for that to register so that you can enroll to the protocol. As soon as someone from your site has completed that training requirement within CTSU, it automatically fulfills that protocol requirement. It is a seamless system. It shows up within RSS. So everything new, the legacy trials, anything that was currently active will remain in the system that it was, with the exception of 1918. Everything new will be in CTSU class. So hopefully that'll make your lives a little bit easier and save you that 3-day timeframe for eligibility and enrollments. And then the other thing that I wanted to mention is that we are also focusing on protocol-specific training and providing more of that for site initiation visits. So historically, you may know we really only provided that if there was, say, a required questionnaire or something, a correlative component that required training, or if it was a registration trial. Now we're going to be providing that for all high complexity trials. So that's all phase 3 studies and all DCP studies. So hopefully that will help. The phase 2 studies are in the future. Need to build the capacity of our program. I'm going to focus on the larger resources first, and then we'll add those in the future as well. So that's the overview of the highlights. This is just a slide that shows you how to get to the clinical research resources that I mentioned, and some good links to check out. I really encourage you to go if you have not already looked at these things. And if you know anything that you use internally that's a government resource that's not there, let me know. I want to make it available to everyone. This is our clinical trials training course. Many of you may have taken this at the SWOG group meeting. We are still, of course, offering, we're so excited to be back in person, that in person. But for anybody who is still not able to travel, we understand there are a lot of resource limitations, especially with turnover rates right now. All of the content in the CTTC is recently updated and congruent with what is being presented at the meeting itself. So anybody can go in and take that training. And that's how do you get there. These will be posted. And this is what I am really, oh, this is not the right slide set. Okay, so I will speak to this. I wanted to show you the slide set. We'll make sure to get the right slide set posted. The other thing that I wanted to announce was something that our group chair's office is doing to make sure that you have all of the specific information in a patient-friendly format for each new trial. And those are our patient-friendly summaries and social media toolkits. They will now be accessible from CTSU for all newly activated trials. They're currently accessible for S2013 and S1914. So if you have those trials active, you can go find them on CTSU. They're under the CIRB documents and the participants materials or recruitment materials. So go check those out. They're really helpful. They're written at a middle school level, and they are going to be standardized set of questions that are addressed for every protocol across the board. So hopefully that'll be helpful in providing information to patients for consideration of the trials. And I will have that specific access slide accessible in the one that's posted online for you. So now, please take out your cell phones. I'm very excited about this because we have recently launched some FAQs on the website under clinical trials, frequently asked questions on our website. They're publicly accessible. You can access our new FAQs that should hopefully address all of the logistics of cooperative group and SWOG specific studies. So if you can please text Courtney Will 940 to 22333. You should get a confirmation. We'll do a little test question to make sure that everybody is able to actually participate. Now here's the thing about the test question. You can't actually text the answer till I get to the next slide. Why did we do that? Because you can't see in the poll everywhere slides, the questions, the answers. So are you ready to get started? Yes, wait, and why not? Okay, so text your answer. Yes, A for yes, B for wait, and C for why not. And it looks like everybody's ready, so we're gonna keep going. All right, thank you guys. So true or false? We're going to go through these speed round. When a patient is on treatment arm with both investigational and commercial agents, the entire combination is considered investigational. Is that true or false? All right, and it looks like the responses have slowed down. So true, you guys are right. So if there is any investigational agent at all on the arm, the entire regimen is investigational, and you have to use that SAE reporting table for reporting. If there are any questions, like the patient stopped the investigational agent, but is still continuing on commercial agent, and you're questioning whether you should report using the commercial or the investigational table, contact our SAE program and they will let you know. It depends on the timing. We are closing out the study and we have leftover drug. We should return the investigational agent to the supplier or distributor. True or false? Text your answers to 22333. Okay, about half and half. We'll wait just a second, see how it's going. There we go. Half and half. So the answer to this is false. It's a trick question. Sorry. For a lot of industry studies, they will have you return the study drug. For a lot of cooperative group studies, what they're going to do is it's going to depend upon what the agreement is with the manufacturer. A lot of times you'll just destroy that study drug per institutional procedures. A lot of times you do have to return it. Sometimes you can transfer agents between patients if it's not drug specific, patient specific drug, not usually between studies, but between patients. You can find this information in section 3 of the protocol. For anything that's a CTEP held IND, you would contact PMB after hours at mail.nih.gov. And for anything that is a SWOG held IND, it's going to depend upon the agreement with the manufacturer, with the industry sponsor. And it'll be specified in that section of the protocol near the end of that study drug in section 3. And of course, you can contact us if any questions. Please do always contact us if questions. Okay, so starting in the spring of 2022, all new trials. Oh, nope, wrong slide deck. Hold on. I skip. Any grade 3 SAE that occurs within 60 days after the last dose of investigational agents must be reported within 10 calendar days unless otherwise specified as exempt in the additional instructions, exceptions, or SPEAR table. Is that true or false? Okay. So again, this is a bit tricky. The timeline is 30 days, not 60 days. And the investigational agents must be possibly, probably, or definitely related to the investigational agents. I must have been tired. The adverse events must be possibly, probably, or definitely related to the investigational agents to require expedited reporting. So that's very important. The attribution is important, and the timeline is 30 days. True or false? Revision 1, 2, 3, 4, 5 was just distributed. I can locate SWOG recommendations for patient notification and reconsent on the SWOG cover memo accompanying the revision. Is that true or false? Not sure what's going on. We'll go on. It is true. The SWOG recommendations for whether or not to notify patients are definitely in the revision cover memo. They're also, these same instructions are in the CIRB, if it's a CIRB approved study, CIRB amendment review form. And if there are any questions, contact protocols@swog.org. A lot of people miss these instructions because there will be a patient notification requirement up at the top of the cover memo that says notification not required or notification required. But then you have to go to the end of the cover memo after the summary of changes. And that's where all of the very specific instructions about timelines and who has to be notified reside. So that's good to know. SWOG only utilizes fixed price agreements for site payments. Is that true or false? Very good. It is false. As you know, starting in, I believe it's 2019, SWOG NCI mandated fixed price agreements. So you have to have 2 fixed price agreements, one for NCTN and one for Encore studies. But then you also need 2 purchase service agreements as you historically needed, one for federal funding and one for non-federal funding. And if there are any questions, this is the key. Contact Kyle T or Debbie Allen, and their contact information is provided on the slide. And Kyle is the contact for federal funding. Debbie is the contact for non-federal funding. True or false? On the SWOG CRA workbench, I can find an updated creatinine clearance calculator under resources. And everybody says that's true. I'm so sorry. I'm good about trick questions, and I really didn't mean to. I'm just trying to like highlight the common misconceptions. It's actually under the tools section on the CRA workbench, and I see many of you cheering out there. So these are incredibly helpful tools that our data center has provided. Our data ops center works very hard to provide you with helpful tools. There are very good resources under resources, and then there are very helpful study specific calculators under tools. True or false? I cannot access CTSU. I forgot my password. I'm receiving an error when I try to log in. I didn't change my password. I should contact the data coordinators for help. All right, good job. No, so unfortunately, we're not able to reset any login credentials. That all has to go through CTSU. There are some very helpful links here. If you are having trouble, because the FAQs for CTSU are on CTSU, which you can't log into. Hopefully that will help you should that occur. Are specimen collection kits supplied? Select the best answer. And we're going to go to the next one. So as I read through them, you can select the answer. Yes, they're supplied for all specimen collections involved in the protocol. You can locate the kit provision. If you can't locate it, contact the protocols department. B, if the SWOG protocol involves a collection with tubes other than EDTA, SSTs, or heparin tubes, kits will be supplied. C, when SWOG supplies specimen collection kits, they are always supplied through the SWOG specimen repository management application through the nationwide, our biospecimen bank. Go to the application and check it out. And all of you are getting the right answer. Word to refer to the SWOG specimen tracking system is D, and E is the answer. You have to refer to section 15 of the protocol. They're supplied in many different ways. It will be specified in section 15 of the protocol. And I want to stay on time, so I'm going to do one more. For protocols with RAVE, CTEP AIRS integration, the expedited reporting evaluation will automatically generate recommendations for AEs that should be reported as SAEs after information is entered or changed on the adverse events report. Is that true or false? Again, it's a bit of a trick question. Sites have to manually run the expedited reporting evaluation after entering any changes. So if you go back in and update anything, you have to go back and rerun that report. Otherwise, it won't show up. And any changes you make, could affect the reporting recommendations. So can we go ahead and skip to the last slide? Because I think I'm at time. And I wanted to take a moment, actually 2 minutes, and thank you for all that you do. And we know there's a lot of stress on resources right now. We know that there's a lot of turnover. We know that there are always new requirements coming out from NCI and SWOG and process changes and a lot to keep up with. So we really do appreciate all that you do to make our study successful. Again, if there's anything that we can do to help, let us know. You can reach me at training@swog.org, and a really long list of priorities of things that we're rolling out within the next 6 months. And I would love to add whatever it is that you need help with to that priority list, or I might be able to let you know which training it's going to be in when that's rolled out. Thanks, everyone, and I'll try to exit a little more gracefully than I entered.
Thanks so much, Kira, for a great presentation and a lot of fun and a few trick questions. Trust me, she really is helpful about this. I want to move right along to our next presenter, which logically follows because this is Krishna Chathwani from CTSU, and she is with us remotely today, I believe, but she is going to help answer some additional and supply some new information from CTSU. Krishna, thank you.
Well, thank you for that introduction. Thank you, everyone, for having me today. And my name is Krishna Chathwani, and I lead the CTSU protocol team. And so with that, if you can please go to the next slide. And the topics that we'll cover today are the compliance learning and SOP solutions or class. We'll talk about the identity proofing and multi-factor authentication, IP and MFA. We'll go over some CTSU reports that are available on the website that you can pull, and then I'll just cover some of the reminders about resources that are available on the CTSU website. So with that, next please. Thank you, and one more. We can go to the next slide. So we'll first talk about the compliance, learning, and SOP solutions or class. So class is the learning management system hosted by the CTSU, and everyone with an active CTEP registration status has access to class. Class is integrated with several CTSU and CTEP applications. And for example, the BRSS, CTMB, AIS, and SDP. And some courses in class are assigned, others use self-enrollment. So if it is a course that is you'd self-enroll onto, you would log into class, go to the catalog and find, enroll in, and then take the course. And like it was mentioned in the previous presentation, class will automatically send the record of training completion to any other system that needs the training completion information. So that's the beauty of it. You take your course, you complete it, and RSS, for example, would automatically in real time receive the completion of the training. So now we can go to the next slide, please. Thank you. So types of training that are currently available in class. Those are trainings related to protocol specific requirements. For example, at least trainings where at least one person at a site must complete a specific training in class for the site to obtain site registration approval. And a couple examples of such trainings are the Alliance Geriatric Assessment Training or Geriatric Training course that is used on SWOG 1918 and the S1900G training webinar. There are some trainings that are required for access to specific applications and are assigned based on user's role. And examples of this would be the Teradex specimen tracking system. Teradex specimen tracking system training used for NCI COVID trial. it's a training that was automatically assigned to rave CRAs at the sites with particular studies open. And those individuals got an email from class informing them of their assignment. And another example of such training is the Source Document Portal, or SDP training, for auditors to access modernized application, the modernized Source Document Portal application. And then finally, there are trainings that are required for certain job duties. For example, the auditor training that is automatically assigned whenever somebody is selected to serve as a site auditor. And again, they too get an email from class about their new assignment. Next slide, please. And this slide covers some of the planned future trainings that will be available in class. There will be additional protocol-specific trainings, as the previous presenter talked about, and application-directed trainings, and also organizations or group-specific trainings. Next slide, please. Thank you. So in terms of what's new coming soon, there'll be 2 new ways to access class. Approximately sometimes next month, there you'll see a link to access class under the quick links on the dashboard. And as a top level link, as we see in the second screenshot, as a top level link on all the screens. And this will both be available on the CTSU website. Here we go. Okay, so next we'll talk about identity proofing and multi-factor authentication. Thank you, you're faster than me. So definitions, this slide goes over some definitions in regards to IP and MFA. So digital identity is the unique representation of a person engaged in an online transaction. Identity proofing, or IP, establishes that a person is who they claim to be. IP can be confirmed using a driver license or passport, either in person or remotely. Digital authentication establishes that a person attempting to access a digital service, that is a website or application, is in control of one or more valid authenticators associated with their digital identity. A single factor authentication can be something like a password, which is what we all currently do. Multi-factor or MFA adds in something you have, like a badge or a PIV card or a cell phone with an application that can receive a token. And this is what the new process is going to be. Next slide, please. Thank you. All right, so overall, NCI is required to follow the National Institute of Standards and Technology, or NIST, guidelines regarding system access. So where is all of this coming from? Well, this is NCI is required to follow the NIST guidelines. And this is regulated by Congress and required for compliance with the Federal Information Security Management Act, or FISMA. And according to the guidelines, username and passwords alone are no longer adequate. And therefore, NCI needs to incorporate IP and MFA into system access procedures. And here we have a link to the NIST Digital Identity Guidelines for more information, so you may access it at your leisure. Next slide, please. Thank you. All right, so the requirements for NCI. So the updated authentication requirement applies to everyone with a CTEP IAM account and any system using the CTEP IAM credentials. This includes all NCI CTEP, it includes all NCI CTEP CTSU systems, including the RCR, CTMB AIS, the CTSU website, Open, Rave, Encore, CTEP Airs, etc. All other systems, including the LPO websites that use CTEP IAM for access. And it applies to all users, including NCI, LPO, contractor, and site staff. And the guidelines require that the users follow requirements that correspond with the type of data the system contains. So there are 3 possible levels, and NCI requires the second level for both identity proofing and authentication, because the type of information our systems contain, this is because of the type of information our systems contain, and that is patient and financial information. So with that, we can go to the next slide, please. So what does this mean? So as part of this process, of the IP process, users must set up their second authentication method, that is installing an authenticator app on a smartphone. When users log in to NCI system, they'll use their ID Me. Yes, I'm sorry, I just got distracted for a second. So when the users log in into the NCI systems, they will use their ID Me username and password. They will no longer use their CTEP IAM credentials and must complete the MFA process to access the system. So it will be a different way of logging in. Next slide, please. I think the slide's here. There, thank you. So once a user has successfully accessed an application, moving to another application using the pass-through process and deep link workflows will continue to be the same. So no changes there once you have logged in the new way. Users who need to sign something within the NCI systems, for example, registration documents in the RCR or a delegation of task log, may be prompted to complete the MFA as part of the signature process. And again, this is depending on, it's time dependent. So you might need to go through it one more time in that case. About general timelines, the updated authentication workflows will roll out in or around June 2022. It includes the release of new login screens. Then new users, those requesting the CTEP IAM credential for the first time, will follow the new workflow. That is, they'll have to go through the IP and MFA setup with ID.me from start. Current users will have a choice to log in using CTEP IAM credentials or to complete their IP and MFA setup with the selected provider, that is ID.me. And current users will have 1 year to complete their IP and MFA setup. And just to note here that once a user sets up their IP and MFA, they can only use that new method moving forward. So anybody new coming on board that is requesting CTEP IAM credentials will start using the new process. And the rest of us will have up to 1 year to complete IP and MFA setup. But once we do, we can only use the new method moving forward. And the full implementation will be in or around June 2023. And at that point, everybody must use the full IP and MFA method. Okay, next please, thank you. And so this is a screenshot of the new interim login screen. Next slide, please. This slide shows some information that is provided within the CTEP IAM profile page. And you can go to the next, please. So in terms of next steps and resources, just say stay tuned for more details around this topic. As more information becomes available, the CTSU will announce that in the CTSU newsletter and the bi-monthly broadcasts and group meetings like this, and we'll also have some resource materials available in the future. And with that, we can go on to the next slide. Thank you. All right, so our next topic is CTSU reports and what sites can find on the CTSU website. So This slide shows reports that can be pulled by site staff from the CTSU website and the Oncology Patient Enrollment Network Open. It includes current roster affiliations, person roster reports, current IRB approvals and site registrations, patient enrollment reports, and accrual reports. Reports that may be obtained from the LPOs include the list of subjects of treatment and in follow-up. Next slide, please. So to pull up the current roster affiliations report, navigate to RUMS and org roster browser and org roster tree. And you'll see the output will be based on your roster affiliations. You can click on the I button that's available wherever, in whatever screen you are. If there is an I button, you could click on it to view detailed site information. And under this report, there is the site button is available. Site I button, excuse me, is available, and it will provide you with more details about the site. Next, to pull up the person roster reports, again, you'll go to RUMS person roster browser. You'll need to run this report by the roster. And again, it's based on your roster affiliation. And here you do get the ability to filter and or export the output to Excel. Next, please. Next, we have the current IRB approvals and site registrations. And to pull this report, you navigate to the regulatory section, regulatory and site registration. You can run this report by site or protocol and export contents using more commands icon that is available on the page. Next, to pull the patient enrollment reports, you would go to the Open and History tab. And here you can use filters, set date parameters, and export the output to Excel. And just as of February 17, 2022, the Excel export features demographic data and disease codes when it is available. So that's just some more information there. And then, finally, we have the dashboard. Much of what we just saw in regards to reports can also be found in the dashboard. And dashboard portlets are user specific and have export functionality, which is available by clicking on the more commands icon on the page, as we see on the screenshot. Next, please. So about accrual reports. Accrual reports can be pulled from the protocols area. From the protocols area, use the tree to access different types of accrual reports. And it's shown here on the screenshot on the slide. And you could do this for the NCTN, ETCTN, Encore, NCI, AYA, and CCDR. And this page provides the ability to filter by protocol status, phase, and by group to further narrow the results. And then, like we saw on the other pages, you can use the more commands icon to either print or export the output. Thank you. So you can also use the protocol-specific homepage to access detailed accrual information, including steps, plan, and actual accrual, as shown in the screenshot. So view detail, by clicking on the view detail, will show pie charts for each accrual step. And then clicking on the pie chart itself will take you to the reports area and to the detailed accrual information by site. So I'll see that on the next slide. Thank you. The reports link shows accrual by site. And you may use filters to search other protocols or other steps for a protocol. And just an important point to note here is that the step type must always be selected for it to show data. And finally, labs have additional reports available as shown in this screenshot. Next, please. Study agents report. This is available in two places. First, under the protocol specific page. And another important thing to note here is that the version of this report under the protocol specific page is the only place where it indicates whether PMB distributes the agent. Another version of this report is available under the reports folder. And the version under the reports folder is where you may search for different protocols or agent. As I see, we'll take the questions. I'll attempt to answer the questions once I'm done. Just a few more slides here, so bear with me, please. Alrighty, so I'll conclude my talk with a few reminders about available resources on the website. Next, please. Thank you. So we have help topics. Help topics appear on most CTSU screens, and it has replaced the user guides. Help topics are unique to the screen being viewed, and clicking on help icon shows the dropdown. So as we see here on the screenshot, they're available on most of the screens. So hope that everyone is using it. Next, please. And along with help topics being available on most of the screens, they're all also posted in a central location, and that will be under the resources section under CTSU operations information and user guides and help topics. And the last, I guess, but not the least, is our 10-part module that provides a high-level overview of each area of the CTSU website. It is in this particular slide sets, the 10-part module is intended as an introductory training resource for site staff that may be new to your institution or to CTSU. And it is available under resources, CTSU operations, general procedures and training, and site staff orientation. So with that, I am done. I'm going to try to look at the chat and answer any questions. So thank you for your attention.
Thank you so much for your presentation. There are 2 questions in the chat, and I think they can be answered relatively quickly. So if you could look at those, and then right after those answers, we're going to take a very quick 5-minute break so you can stretch, grab 1 more cup of coffee, and then we'll dive into our panel. Krishna, can you see the questions in chat?
Yes, I'm looking at it now. I'll respond via chat if.
Great, thank you very much. So for those of you, your answers will be in chat, and if you want to take a quick stretch break, please do so.
Those are about the MFA. That's a great question. I'll have to take it back up internally and get back to you. So we can, I guess, while the meeting is ongoing, I can actually reach out to people here and see if we can get you the answer today itself. And so that was, I see a question. I'm not sure if that applies. Will we have the option to save the information for 7 days like we currently do with RAVE? I'm not sure if that's what that pertains to. Anyone can help me. Feel free to help me out here.
Krishna, there was just 2 questions for you.
I only see on, thank you, Joyce. I only see on my side, I only see one about the multi-factor authentication. Well, I guess that's one chat, but yes, there are.
Right, Mandy asked, will we have the option to save the information for 7 days like we currently do with RAVE? I'm assuming she's talking about the reports. Mandy, if you're online, do you want to speak up?
If you do pull up a report, you do have the option to, wherever, it depends on what screen you're in and whether the option is there, but you could use the more commands icon and either print it or If it lets you download it as Excel, you definitely can save that Excel sheet.
And then the other question was about the multi-factor authentication.
Yes,
That's the
I
one that
will-
you will follow up with?
Yes, I
Okay.
will check in here and put my response back in the chat.
Okay, thank you.
Thank you all.
It's okay, I'll work there. You want to trade?
Okay.
No, you can't see it anywhere.
Oh, I thought you want to look on. You want to look on this side?
Hi. I want to have Dana's dashing down the aisle. I want to welcome everybody back to the panel discussion. Give everybody a minute or two to come back in. So whenever we present on a subject like this, it presents a lot of challenges. I think everybody who has lived through the past 2.5 years knows what those challenges look like, knows how impacting they've been for your site. But one of the things that I think is so incredibly important is what's been shared from the NCI. Andrea Denikoff spoke at a lead academic participation site call and made it very clear that the NCI was reading our progress reports, reading the RPPRs they're called, and really noting the challenges that we have faced and really trying very hard to be supportive of that. I took great comfort in knowing that, especially given the challenges that we faced with our colleagues departing and going to different ways of working, different companies, and all manner of changes in our sites. So when we were brainstorming how to present this, we thought we would help to kick off the idea of both an open discussion about it with questions, as well as an ongoing discussion about it, because it is, while it is somewhat new, it's not going to go away. We don't, and none of us agree with that. So Deb Bergevin and I and Tasha and Connie put our heads together and talked about this as a panel discussion. And I want to thank each and every one of them for all of the thought that went into this. I also want to thank our presenters, because they kind of did this on the fly too. Michelle Markham, who is at the University of Cincinnati Cancer Center, Kate Bryant Greenwood, who's calling in from Hawaii. Wish I was there, Kate. Jessica Molly from Huntsman Cancer Institute, and Connie Shapanik, our chair of the ORP and the lead of the Cancer Research Consortium in West Michigan. So if I can start the slides with Michelle's, we're going to talk a little bit about what it's been like at our sites. We have 2 sites that essentially represent academic cancer centers and 2 sites that represent communities sites. So different perspectives, but a lot of similarities. Thanks very much, Michelle.
Great, thank you so much for having me. So I'm Michelle Markham. I'm the director with the UC Cancer Center Clinical Trials Office. I've been with UC since January of 2019. And prior to that, total I've spent about 19 years working in clinical research. And that has all been either directly with cancer clinical trials or cancer population health studies. And so I've had some various experience throughout those years. Next slide, please. So to tell you a little bit about UC Cancer Center, we've been longstanding main members of SWOG and NRG, and then more recently have also joined the Alliance as main members. Currently, we have around 60 staff in our clinical trials office, and we manage right around 300 trials in our portfolio and have on average now around 135 that are openly accruing. Like many centers, we did see a dip in our enrollment during the pandemic, and since have seen those numbers start to rebound. Next slide, please. So particular for our center, we are on a pathway for NCI designation. So we're very much in a phase of growing and building across all of our programs. And so in calendar year 2021, we had a lot of turnover, the highest turnover that we have had, and it was about 37%. It really was not isolated to any one area in our office. It impacted all of our teams. And then when we were posting positions, what we're seeing is fewer applicants with less directly related experience. And for those, when we do have applicants that have directly related experience, we have a challenge in our local market to offer
competitive salaries against CROs and pharmaceutical companies. In addition, we have some challenges with our trial portfolio. So as I mentioned, we're growing and building across all of our programs. So we've seen an increase in our number of open trials, about 40% compared to the prior year. And then in particular, early therapeutics is an area where our center has identified, as one of our strengths. And so we have seen a 50% increase in early therapeutics trials as well. And so, with the two of those combined, what we're seeing is in the last year, bringing in staff with less experience and then asking, them to be able to support some more complex studies. Next slide, please. So very quickly, we had to develop some strategies around our staffing. And so when it came to identifying staff that maybe had those higher levels of directly related experience, we have used contract employees. So we are able to, execute 12-month contracts for those staff, and then hopefully reduce the burden to our existing team, as attrition happens. We also have increased our flexibility for remote work. We do offer some fully remote positions that allow for that, like our regulatory roles, and then others we have hybrid options. We've really focused a lot on our training and education. So we had started some initiatives prior to the pandemic, but then during the pandemic really accelerated our work and focus in those areas. So we have created workflows for job tasks across regulatory, patient-facing coordinators, data coordinators. And then we've really formalized the preceptor role in our office. So we have expectations for the preceptor, preceptee, and then in collaboration with our educator and the manager. And so we really see that as an ongoing collaboration while that new person is, in their training, onboarding and training phase. We have also started utilizing our university's learning management system, Canvas, for our educational content, where we have videos there, some mock materials, mock protocols, quizzes. And the goal of this is really to be able to have, both that hands-on training with the preceptor and then some self-directed, self-paced learning that individual can do and access, easily. We've also standardized tools to increase compliance. So through use of Epic Smart Phrases, we have templated notes for medical history, ConMeds, AEs, disease assessments, informed consent, anything just to help create, and ensure that each note is hitting those key elements for that highest quality of source document. But what it also does, and we've actually been able to measure, is it's also increased our compliance with the timeliness and investigator sign-off. So we do conduct internal audits, and we were able to present some data both prior and then after implementation of some of these electronic tools at the AACI-CRI meeting last summer around, those internal audit metrics as a result of these Epic Smart Phrases and electronic tools. Next slide. So our longer term goals for our staffing is really to partner with our HR and other departments in the university. We're evaluating job codes, salary ranges, expanding position titles, and our goal is really to embed competencies within the clinical research professional titles at our institution. We're also collaborating with our CTSA program and the university for a clinical research staff training and certificate program. Again, we'd like to partner with HR. We've discussed being able to incorporate this at the time of hire as recognized when someone is hired, that they have that certificate in place or would soon thereafter. Our CTSA, they have a master's degree program, but it's really designed for professionals that are already working in the field. And so we see this as a way to, bridge that gap for staff that are interested in a clinical research position or career and haven't had that background yet. Then for our trial portfolio, we really needed to look critically at how things were, coming into our office overall. We did pause intake of new trials for just a couple of months. And then when we resumed intake, we did it with some parameters in place. We're really partnering with our disease groups, and we are evaluating the accrual targets, their annual accrual targets for all of their open trials. So we've set some benchmarks for those disease groups and their programs. And essentially, if they're not meeting those, then we want them to be thinking critically about the studies that they're putting forth into startup. And really, hopefully, target those that are going to have higher annual accrual goals. If they still would like to open a study that's maybe a more rare disease, then we ask that essentially they look at studies in the portfolio that aren't accruing as well, and consider closure, especially if they've been open, for some time. We know there's a risk to this in, how we use our resources. So we are partnering this accrual review and the accrual targets with our disease programs, our feasibility committee, and then also our scientific review committee is taking all of this into consideration when we vet new trials and startup. This we just started in January, so it's a little bit early, but we're starting to kind of get a sense now of how things will go, but we'll continue to evaluate this going forward and see if it helps our program overall. Again, we don't want to restrict trials, but we want to make good use of the resources we have and just be mindful of, overburdening our current staff and things. So those are all my notes. Thank you.
Thanks very much. I want to introduce Kate Bryant Greenwood, who's our next speaker on the panel.
Hi, everybody. Good morning. I wish I could be in Seattle with you all in person, but we have a fantastic, small but fantastic team representing us there at the meeting. My name's Kate. I'm the manager of the Clinical Trials Office. Thanks, Michelle, for your presentation. Lots to think about there. We are a University of Hawaii Cancer Center. We're also a Hawaii Minority Underserved Encore. I'm the administrator. We are interesting and set up quite differently. Here at University of Hawaii Cancer Center, we are NCI designated, but we also hold this Minority Underserved Encore grant. We have no clinic, hospital, and we are 100% community facing. This is a very different structure, and we've had challenges because of this. We are structured differently in that we provide regulatory, specimen, all these centralized services. Plus, a lot of the clinical research coordinators we hire and send out to our affiliate and sub-affiliate sites. Most of them are non-RNs. While two of our primary hospital systems provide research nurses, research nurse coordinators, majority of all the data entry, study conduct, audit prep, long-term follow-up are entirely done by the Hawaii Minority Encore Network housed with us and our staff. As our PIs, Dr. Berenberg and Dr. Okoba have said for the Encore, this is why this current staffing crisis has really hit us hard and so profoundly. I won't go into all the numbers, but on average, in normal times, we accrue on an average of 200 plus patients per year, and most importantly, 84% are non-white minority accrual on therapeutic trials. Next slide. So, pre-COVID, we weren't doing very well. We were experiencing 50% turnover, primarily in the lower ranks. This was really simply because the entry-level folks, majority would move on to medical school or PhD programs, which we were really proud of them for. But this, of course, takes a toll on existing staff who are as Michelle mentioned, preceptors or having to train new people coming in. So pre-COVID, essentially from 2017 to 2020, it was an average of entry-level staff 50% turnover in general. And of course, we all know COVID then hit, and now we're suffering from the indirect impacts of COVID. We've lost 70% of our experienced mid-level research coordinators. Again, these are non-RNs primarily. And as we all know, like this is an unprecedented, unheard of nationwide staffing shifts. What we have done previously to COVID that has been working, similar to what Michelle Markham has done at University of Cincinnati, is we created, with the help of our previous cancer center director, a clinical research professional certificate program that really was focusing on clinical research, was specifically on oncology, to try to reach a broader labor pool. And that has really been helping. We've offered that in-person hybrid every fall for the past 3 years, I think. And it's really helped us, and we continually reach out to those who've completed the certificate program. But like I said in the previous slide, and I mentioned, because we have most of the staff that then go out to our sub-affiliate and affiliate sites, the impact has been really quite large in comparison to maybe other sites where they're using employed staff at their various network, within their various network. Next slide. I also wanted to mention that in addition to, from the previous slide I didn't mention, is that here we've had a lot of staff turnover. Where have these folks gone? Of course, like everywhere else, they've gone to pharmaceutical companies. We all know that this is now offered with remote work. This is unprecedented for a state like Hawaii. We've never had these jobs available. So it's not a bad thing, because obviously they can pay more, but this has never been a thing for us. Obviously, Hawaii is not Boston or the Duke Research Triangle. We haven't had pharmaceutical companies in our backyard. So that is new, as well as I might add, obviously the cost of living increases. Everyone nationwide is facing that, but acutely here, housing costs have been higher and higher, even pre-COVID, and now they're almost unsustainable. So it's really driving workforce away from Hawaii, as well as forcing folks who would like to have stayed with us, but need to actually find increased pay quite desperately. Anyway, so that was from the previous slide. Our strategies and solutions. This is a big shift for us, and these are big changes. It's an opportunity to ask, what's working and what is not working. We obviously have to be mindful that our affiliate hospital and clinic sites are likewise suffering staff turnover. But we hope that with increased communication, asking for assistance, we can work through this. We're not really sure yet, as many maybe you guys out there are similarly situated or in the throes of things. You don't know how the dust will settle, but we are in the process of figuring out, who and where the responsibilities will lie, and making those shifts. Especially as everyone knows, oncology research is so complex. You need experienced people, which everyone is really lacking. So having those conversations, and hopefully even maybe with sites taking on responsibility for certain trials. And of course, the second bullet point is, it's unfortunate that it took a dire emergency, but it is a great motivator. Obviously, you guys know that there have been silver linings with COVID. We've been trying to toss around the restructuring and career ladders for several years now, but the actual push is now upon us. So it's actually a really positive thing. Next slide. So As I'm kind of learning as I'm going, because I'm not an expert in this, but a part of business administration is change management. And for us, we're in really kind of more dire straits. So we are really focusing in on massive change. As the second main bullet point says, you know, focusing in firstly on our vision of creating new org charts, rewriting job descriptions, and justifying salary adjustments. These are all really big, heavy lifts. So meanwhile, we're also trying to continue our program and sustain our accrual, our quality, and all of that. But we have to get this done. And I wanted to share these top bullet points. And, you know, these are the key things that I'm trying to ensure that we do successfully. Obviously, engaging stakeholders are key. Who are our stakeholders? Well, obviously, some of you guys may have, you're employed by your actual institution. Myself and our clinical trials office staff are employed by an outside institution. It's affiliated yet separate. So that is obviously a key stakeholder that involves human resources, that kind of thing. Who else? Well, obviously our Encore, our network partners who are crucial because again, we don't have a clinic. Investigators, our clinical faculty, and our key investigators that are the top enrollers. And of course, the most important are our actual staff who we're trying to rebuild, we're trying to retain. Those folks are the key stakeholders in all of this. So I wanted to add too, in terms of salary adjustments, most of you guys, and I don't know if Michelle, sounds like you have a lot of HR support. HR, it seems like in a lot of well-resourced centers can provide wage analyses. We had to do more of a grassroots homegrown system. We have a staff member who is familiar with change management and was willing to go into the job boards, you know, LinkedIn, Indeed, Monster, and pull out and make a very nice matrix of positions that we have with all of these salary comparators. So if you guys need help with that or want to reach out to me, I'll put my email address in the chat. That we've done, of course, with the caveat that it gets outdated quite quickly, within probably like 3 to 6 months. But nonetheless, this is part of justifying salary increases that I personally believe have been long time needed. Additionally, kind of what others probably will mention is robust education and training. I think similar to Michelle's, I think it was called the Canvas, we use something called MindFlash. It's an online education sharing platform. We found it very useful. Of course, you do need FTE to help organize it and kind of staff it and make sure it's up to date and share it. It's a portal for sharing PowerPoint slides, discussions. You can even record, you know, if you have staff meetings that are crucial, whatever it may be, it can be shared and organized well. We have that and are trying to better utilize that. And additionally, even though we are short-staffed, we have several key people involved in creating disease site trainings because, as we all know, entry-level folks coming into oncology can get pretty overwhelmed very quickly. And my last point is editorializing of why is this important for, I consider us a smaller Encore, for us to stay viable? Well, it's diversity, equity, and inclusion, right? There are sites like us and others nationwide that enroll patients, you know, from very unique and very important populations, and we have a duty to maintain that and sustain that into the future. And I'll be sure and put my contact information in the chat. If anyone, feel free to reach out to me or us, and I would be glad to talk and help others in any way I can. Thanks.
Thanks, Kate. We'd appreciate if all of our panel presenters would put their information in the chat so that it's visible. We're going to move on to Jessica's presentation.
Hi there. Thank you for having me today. My name is Jessica Maley. I'm the director of the Clinical Trials Office at the Huntsman Cancer Institute at the University of Utah, located in Salt Lake City, Utah. I have 18 years of research experience and have been at the Huntsman for the past 16 years, serving as the director of this office for 7. Prior to that, I was managing our regulatory work, and we've been a SWOG member for many years. I have previous experience at the NIH and the National Institute of Allergy and Infectious Diseases. Next slide. So the Huntsman Cancer Institute is an NCI designated comprehensive cancer center. We're also an NLAPS site. We have 160 FTEs in our clinical trials office, centralized for adult oncology intervention treatment studies. We serve a 5-state region through the Intermountain West. We have a new catchment area beyond the state of Utah that includes Idaho, Wyoming, Montana, and Nevada. We have about 500 active treatment trials in our portfolio. About 220 of those are open to accrual. And we had a record year last year in 2021 for new patient accrual, putting 783 patients on treatment trials. We've been a member of SWOG since 1989 and enrolled 86 new patients to SWOG studies in 2021 and have about 26 SWOG studies open to accrual. Next slide. So we had a high number of trials activated in 2020. I think that it was a year where a lot of oncology clinical research came through the pipeline and did not slow down. There was a record number of grants during that time, as well as contracts and new clinical trial opportunities in the oncology space. Additionally, compounding leading up to 2020 and the pandemic year, we had recruited a number of new medical oncology and hem-onc faculty into our center, totaling over 40 new clinical faculty by the time we got to 2021, and many of those individuals were ready to do clinical trials. Every PI and disease team says yes to most studies. I think we know this, and so we had to put some guidelines in place to help them manage their portfolios as well as our growth, while we additionally looked at the staffing challenges we faced in 2021 that continue on today into 2022. So we have a 39% turnover rate in our coordination team and lab primarily. So it is it's very impactful to our ability to continue to enroll. I will say our 2022 accrual is down this year, given the challenges we're facing with staff shortages and just saturation from such a large accruing year we had in 2021. So we're not letting as many studies through the pipeline and are trying to control the flow. So we have also, I think, weak applicant pool with limited qualified individuals coming through. And I don't think that we are alone in that struggle. Next slide. So I want to make t-shirts that say, slow the flow, save CTO. So when we're centralized this way, it's very challenging to continue to satisfy the service line we're providing as a clinical trials office to our investigators in our institution. We did decide to issue some research group portfolio management guidelines that are related to the best practices around managing a clinical trial portfolio for any one disease area. It's a guideline rather than a directive, mandate, or harsh policy because we felt that we needed to allow flexibility for those investigators to still have some autonomy to fit protocols into their portfolio where it was very much needed. But the guideline really includes like a proposed type of scoring system for studies that are of utmost importance to their area, but also align with cancer center priorities. NCTN and SWOG studies in particular are of import. So we have a feasibility administration review committee where every study that comes through after disease team kind of scoring and evaluation is reviewed not for scientific review, but for feasibility and logistics only. It's a multidisciplinary review committee. And we had to really limit the number of studies that could come into that committee in any given time frame. The priority for what studies we select are those that are IIT, NCTN or ETCTN, and industry, priority being phase 1 first in human, or if we're a lead academic site of some kind, followed by phase 2, phase 3. So it is challenging to have that limit for those disease teams, but we've made it work the best we can. Additionally, we've limited site initiation visits to 3 per week, trying to keep the number of trials activating in any given month at a lower threshold. We have staggered and strategic enrollment holds in specific teams. We try not to put a pause on full disease teams, more specifically individual trials that have accrued well and we are meeting our targets and we can maybe slow down, or those that are highly complex that really we need to stagger and say we can only have 1 patient on this study in particular for X amount of time until they make it through to cycle whatever, so that we can have appropriate staffing and oversight for that patient safety, which is the #1 importance. We did receive out of cycle support for positions from the Cancer Center. However, many have remained unfilled as we've tried to prioritize the replacement positions and keep that work going forward. Additionally, Huntsman was able to bring on a compensation analysis externally to review positions for our fiscal year 23 budget and to make some recommendations for compensation related to individuals throughout the Cancer Center at a market minimum. And so we expect, if the budget is approved, that to result in some significant increases for individuals. Next slide. So one of the high points of limiting the number of trials through that we're activating was that we had actually faster activation times since less were moving through the system. So our activation staff were able to speed along kind of those studies that were coming into the queue. New accrual, as I mentioned, remained exceptionally high, but we are starting to see that dip in 2022. As we have had an increase in the vacancies we have to fill. We have had physician leaders and clinical leadership support through the Cancer Center for our limitations. We want to make sure that we're complying with data expectations, which have been challenging to keep up with, as well as ensuring that the patient safety and overall compliance of the trials we are coordinating remains high. The limits that we have put in place have helped with boosting staff morale, as well as, of course, compensation, but they see that the leadership is attempting to try to slow things down a little bit and give them some reprieve for their workload when team members leave their groups and they are required to do a lot of extra work to cover those studies. Next slide. I think that's all I have. So I'm happy to put my information also in the chat and answer questions at the end. I'm happy to also share details around our CTRG guidelines. We will be doing a poster about that for the CRI committee meeting that happens with academic cancer centers in July. Thank you.
Thanks so much, Jessica. I think that thanks to everybody for sharing their information in the chat. If we can pass it on to Connie, our final speaker.
Well, thanks. I was recruited. As much as I said I didn't want to talk about this topic, our site is not exempt either from the hardships and the challenges of our workforce. So I'm actually going to focus on the workforce challenges. Our program has been in existence since 1975. I've been a research nurse with our program since 1992 and moved into the leadership spot. And in all the years that I've been with our program and before me, there has never been a time like this. It's unheralded. And I know that's the same for many of you too. No one can ever prepare you. As much as you know, this has been a time of what the heck, and how am I supposed to do that? And who tells you these things? So it's certainly been a time of learning. Next slide, please. Our backyard is the west half of the state of Michigan. We have multiple healthcare systems in our Encore, and we have typically 150 to 175 open trials, and then another 200 plus that have patients on study and follow-up. So it's a big portfolio, primarily phase 2 and 3 NCI studies. We're paid according to our grant, our one grant in the community. We only have one main funding source. And so it's a little scary when accrual drives everything, and yet here we are with these challenges before us. Staff changes are rampant. Every one of our membership dots, with the exception of one, has had at least one change, a significant change in the last 2 years. So that's a lot of dots. We have 11 healthcare systems, and not one of them has been exempt from staffing changes except one. Our central office, we have 12 research nurse positions, and of those, we've had 9 new staff members join our team in the last 2 years. So when you do the math, that's a pretty big chunk of percentage-wise. Next slide, please. I think that has been one of our number one challenges, is the turnover of our research nurses. And in a community setting, we don't have a vibrant pool of people that we can pull from who have both oncology and research experience. So finding the right new team members, and not just team members, but the right person who is the right fit, who loves the attributes of research and are hopefully going to be someone who will grow into this field and represent our work for a really long time, has been a big challenge for us. And we've always been really picky, and we still are very picky. We want to invest in the right people. So I have to say we've been really, really, really fortunate. Several of our team members are here today, and if it weren't for our team, we'd be out of business. So finding the right people has been paramount, although it's been very difficult. We've had some positions posted for months, and that's not historically the nature of our business. Our team is tired. People are carrying the load. With every one of those changes, there's had to be a transition plan. We're practically losing control of that. We've now had so many transition plans, we're practically using version control to remember which one we're on. I can't keep track of it. Anthony, you tell me, we've had one transition plan we've changed 10 times in the last 3 weeks. You get up every day and you come in and it's, oh, by the way, yeah, but one more thing. Holy heck, when is this going to stop? That's how you feel some days. So you just really have to just keep on keeping on. That's the moral of our story. So our camel's back is kind of hurting right now. We've got some bandages wrapped around it, but we're not broken and we're not going to quit because this is too important. Next slide, please. Some of our strategies have kind of been, I'm thinking about this, and you don't realize what you've lived through as you live through it, and you get a little bit further along and look back, but thinking about the waves of the pandemic and how we've coped with each of our transitions. We've had really big three big red surges in Michigan. And each one of them, we've done all of these things, but we've really hunkered down and focused on one or two more than another. So I kind of broke the strategies into 3 different kind of perspectives on how we've tried to handle this. When this started, we were all in. We were doing things we never thought we could do. We were working off the side of our bed at home. We had coffee tables set up in the dining room. But we knew it was short term. We were going to get through this. We were going to come back stronger than ever. And lo and behold, that's not what happened, as we all know. So really what we've looked at for our studies, and similar to Jessica, in the beginning, we've always been a never say no. We're a community center. If docs and patients and sites need a study, boy, we're there for them. That's our mission. That's our pure heart. But we've had to say slow but flow. How do we keep the lights on? How do we keep moving? But how can we do it and still do it right? Do it safely, do it from a quality and compliance perspective, and not sink totally. So strategic pauses. There have been times where we said, we'll open a study, but not today. How about next month? We've had key frontline studies that we've said we're going to stop recruiting for the next few months. We have to, because we don't have staff to do it right. We've had offices waiting for us for 6 months to come and develop an accrual plan, a strategy for how we're going to open more studies that they want to do. But we've had to look at return on investment. What can we really do? What will really keep us safely afloat? We've had to reassign our staff to things they never thought they'd want to do. So we're kind of shaking the apple cart upside down. Historically, as an Encore, we have a lot of priority writing on cancer control and CCDR studies, for example. And we used to have a whole team of people that really did primarily those studies. Now everything is everybody's fair game. So we have Clay with us today, one of our newest research nurses, and he hasn't run from the building with his hair on fire yet, I'm glad to tell you. But Clay, for example, is learning cancer control and CCDR and treatment to serve the offices that he treats and serves, which isn't quite how we've done it in the past, but it's sure how we're doing it now. So prioritizing resources, prioritizing studies, looking at what we can do. Next slide, please. In the second wave of the pandemic, we got really even more focused on this is going to go on for a really long time. So how can we make sure we keep on juggling the studies, but really looking at our program and sustainability? It's going longer than we thought. So considering return on investment, for example, targeting our screening. We've been very proud of the fact that we try very hard to screen every patient that comes in our doors at our centers for clinical trials. We've had to stop doing that. There's no return on investment except that the patients get matched to trials, which is pretty important, but we've got to look at creative ways to do that. Our cancer centers are struggling. Our clinics are overwhelmed. There's not enough room in the inn to even sit down and have a consent discussion in our clinical space. So how do we do it? So we've had to target screening. So for example, if the Commission on Cancer accredits a cancer center, we make sure that those disease committees are being screened first, and we might have to pull the plug on others and hope that our docs are going to stay tuned to the menu. It's not anything I like. I'm not proud of it. It's just what we've had to do. One thing that really concerns me and keeps me awake at night a lot is the fact that we've spent decades as an Encore building community relationships. We've really had to pull back on that. We've had to be very hunkered down within our theoretical philosophic four walls as a program, and there's not a lot of ability with COVID and the pandemic constraints to reach out in the same ways. And even if we do reach out, people aren't on the other side of the phone. Teams, they're not home. Programs, resources have closed down. The people that we used to know aren't there anymore. So that for us is going to be, I think, a very impactful change, and repercussions are yet to be seen. But as an Encore, that's a pretty big deal. One of our other strategies from a program perspective is remembering the why. We're tired, but you know, if you really remember what we're doing and why we're doing it, it's why we get out of bed every day and do it some more and do it such harder and over again. So for example, when S1417 CD was released a couple months ago, we told each other that story. That was a financial toxicity study that we really worked hard on, and it wasn't in our bailiwick to do that study. Took a lot of creative thinking, new partners, new everything. So we put it in the Cancer Center newsletter. We sent it to financial navigators, to physicians, to nurses, to our patients. We sent the results and remembered the why of what we do every day to get out of bed and come in and do this more, because we're impacting lives forever. So we have to tell each other our stories and stay super flexible. I think that's a really important key. I don't know if any of us come in and find our checklist that we thought we'd start with and go home at the end of the day and conquer even 2 things on that list by each day's end. So next slide, please. My final slide and thoughts were around the people, and especially in this third wave, as we're continuing, in spite of all the things we're working on together, there are lots of right reasons why people are leaving, but it's painful. And we've had to come up with creative coverage solutions. One of the things that we've done throughout all of this is reconfigure our training and onboarding process, not just the tools and the content and what modules we pull and where they come from, but how we prepare people to do this work. The inability to sit side by side is I think, a big loss in our profession. The incidental learnings, the experiential sharing of wisdom that we have, which makes SWOG all the more important in our forums together important, because some of what we do, you can't learn from a book or a module. You learn it as you learn it on the fly with your patients and your clinics and the people. That's one of the struggles that we've been having. So we took our 2 senior research nurses in our central office and reconfigured their roles pretty significantly, which made me real nervous in the beginning because they're accrual leaders. But our senior most nurse is now our training nurse. She's had 9 team members to onboard. We were trying to share the wealth across everybody, but we had inconsistencies, and it was just hard to keep track of what we told who, when, with learning styles and opportunities before us. I mean, sometimes we can't teach something because it isn't happening yet. You have to wait. Maybe it's 6 months before the big blinger of an AE happens in clinic X. And then everybody needs to learn what goes on when that happens. So it's been really difficult to schedule things purposefully, but having one of our staff be our trainer, that was a whole new role for her and for us, and it's been a total home run. Grateful for her. But that was a big change that we made. Our other senior nurse became our quality leader. I don't know about you, but nothing has slowed down as far as audits and monitoring visits, and all this remote stuff sounds glorious on the front end, but it's a boatload of work for staff. So again, being prepared, representing our site well, but also on the interim, making sure that we're doing our work safely and as well as we can do it. I am concerned at the pace at which we're doing all of this change. There are things that are getting missed. So my big point also is the fact that we need to do things as a team. We need to build process. We can't remember half of what we do by an hour after we've done it. There's just so much going on. I saw a word this morning that I thought was so characteristic of our time, this infodemic that we're in. You know, the barrage of information, the pace at which it's being channeled at us. Process is key. Team is everything. Moving away from tons of formal meetings. We do huddles on the fly all the time. I'm just grateful for the people that we have, and they're just the core of their fiber that gets up every day and keeps on trying. And it's just a good time to remember that we need to be in a judgment-free zone. Not just our team is struggling, but every team I know is struggling or going through changes. And what has really caught my eye is this whole idea of asking for grace and mercy. We are making some errors. We've had mistakes. We're prepping for an audit that's going to be uglier than hell when I get home. But we've done the best we can, and we're doing the best for our patients that we can. And most of the errors that we've had have been something about data, not so much about care. So we're going to ask for grace and mercy. And I think the auditors too, sometimes they're tough, but ask for grace and mercy. We don't know what burdens they've had. Our study coordinators at SWOG, that they've been really hard hit, and they're trying to learn really fast and get protocols out to us. So the team that I'm talking about is our whole universe of we who continue to work together for cancer research and making sure our patients have access to the very best. So I think that's what I'll just leave it at that. Grace and mercy.
So if there are individual questions, thanks, Connie. And if you could please put them in the chat, that includes thoughts. And we are going to a certain extent, leave the floor open for that. I want to particularly say thank you to all the presenters, because I know they focused on something that I find very important to remember. There's a great book out called The 4 Agreements. And one of the things in one of the agreements is that every day you get up and you do the best that you can. If that was the best that day, that's exactly what you have to give. There isn't anything more beyond that, because you gave it your best. Your best will vary from day to day. You know, whether you had a great night's sleep or whether you were up with a 3-year-old, it will all change. But on any given day, give your very best, and then walk away and say, I have done my best, because that is all you have to give. And it's important to remember that. You can advance to the next slide. Tasha, are there questions in chat for us?
Just a couple of comments. Randy chuckled and said, I guess that's a good thing. We are all in the same boat. We can at least sympathize with each other. And I think we can all agree on that. And Kate agreed with you, Connie, with transitions, as everyone knows in healthcare, increased mistakes get made, and then quality is no longer owned due to staff turnover. I think we've all experienced that. And Kira stated, would love to see examples of how sites have onboarded new staff in this evolving environment, especially as it often taxes already stretched staff. And maybe we can come up with some of those. Brandon, I think one thing that is common among all of our organizations is that HR continues to use these compensation analysis to compare their salaries to other salaries in the area. But this method actively keeps wages low, as organizations will continue to say they are competitive if their wages match other organizations' wages. But this just creates a conspiracy among all the organizations to flatten wages. It would make more sense for HR to compare wages to cost of living and inflation. And why isn't HR asking their employees if they can afford to live in their own city instead? And I think we can all agree with that statement as well. And a bunch of thanks for the insights and encouragement.
So our panel felt really strongly that this was going to be an ongoing topic. There were many, many comments about compensation and how challenging it is. And, you know, everybody has addressed that they are relooking at that. So I particularly appreciate the comment that was just spoken out loud. I think we really understand that there are going to be some ongoing short-term employment solutions that we have to use. Sometimes we use contracted agencies, but we all know that those people too have to be oriented, and that takes just as much time and energy. And we truly wish they would be a permanent employee, right? I think we all have acknowledged that there are entry-level positions where there's continuous interviewing and hiring going on. Those folks are with us for a few years, and then in fact, they may go on to other careers. And that actually is a success of ours, to give people a start in an area and send them off into the world, always remembering how important research is, because it is the thing that gives us the next best cure. So, but we have to get used to that cycle. We have to understand that that's sort of our daily life and never really get off the gerbil wheel, if you will. I think we have to look at what Connie and several other speakers were speaking about, the need for education and training on an ongoing basis. It can never really stop, but it really has to be start from a very basic level, because cancer is very, very specific, as we all know. We need career ladders so people have places to grow in our organizations, not have to leave to continue their growth. And while we do acknowledge, and there'll be a slide in just a minute about the competition from industry, many people in a site that I'm currently at have chosen to return from industry because it's not necessarily all that. And money does not make the world go round all the time. But we have to look at the strategies that they use, not just pay, but remote work, flexibility, hybrid models, flexible work hours. We have to be open to those same kinds of models, and how can we implement them at our sites. I think we also are interested in future OISHIs to look at ways to manage very complex trials and to measure the time that it takes to do that. I think we all know that they're becoming more complex, but we have to be able to prove those things to the people in administration to be able to add the positions that we need. Next slide. This is a slide that just really briefly comes from a presentation that was done at the AACI Cancer Administrators Forum a month or so ago. And it was presented by a gentleman named Henry Ciolino, who is one of the major grant support writers at the NCI and is always involved in updates that relate to our grants. And I think the thing that stands out the most and is such a snapshot is the number of people who went off to work in industry. And that's that second bar. So there's going to be more data like this, and data like this helps to drive change at our sites and make the case for what we're experiencing. Next slide. I appreciate the comment in the chat about managers and managing expectations and our colleagues that we work with. I think we all as leaders feel that way. And I know everyone, really basically all of our colleagues in the team feel the same way. Most everybody faced staffing shortages, okay? And it continues. This is not going to go away. The Great Resignation had significant impact, and people really rethought their lives in so many different ways. A lot of solutions were tried. Some worked, some didn't. Some did not have the desired results. There is national interest now at the NCI, at SWOG, at AACI, and in many professional groups. So I think our not losing this topic and hanging on very tight to it is going to be something that will benefit us in future knowledge, future actions, and future solutions. Next slide. We have talked as a panel and as a group about converting this single discussion into an ongoing topic of focus. As I just said, there is strength and wisdom and positivity in sharing what we're all going through. We definitely feel that there's a need to implement a survey of salaries in different geographic locations with types of site and using different models of care nurses versus non-nurses, all those different things need to be taken into consideration. The data needs to be more detailed so that it can be used by each of the individual sites to help make the case for what you need. We definitely need to champion and support programs that expand education. I know at our site, we're working in partnership with a community college. We've purchased a base group of teaching through a CRP, and we're actually running a cancer cohort starting in April of 6 people to help people find their way into research. If you've been in research, you learned that everybody said, I have no idea how I got here, but I love every minute of it. We need to go find those people and help them find us as a career. And we need to participate in work groups to focus on research and expand our efforts to find long-term solutions to this, because those of us who've been in this for a while know this is the best work we've ever done, and we want to continue to promote that feeling. So Tasha, any cleanup from the chat that we need to talk about?
Just a lot of thanks and great presentations to all of our panelists. Desiree had a comment stating, it feels like new hires learning this job are having to learn to drink water from a fire hose, because by the time you get them hired in, the work has backed up so tremendously. The existing staff are so fatigued, and the leaders and the managers are also exhausted. Yet managers have to keep their own morale up and those of their team while enticing new hires to want to join the team. It's tough, and there continues to be a challenge of managing MD expectations, while our oncology clinics are also short-staffed, and MDs verbalize they understand the staffing issues. They also want to get their patients on study. So it's a huge challenge, which will require a multi-layered approach, and the ideas presented here are very helpful.
So if we go to the last slide. On behalf of Deb Bergevin and myself and the rest of the ORP committee, we want to ask you to keep your ideas coming. We are new to this role, and we are looking for what our next set of topics will be. So if you want to email us directly, we're very happy to hear your suggestions, your comments, and your focus areas that you would like covered in education. This symposium is about us and our work, as Connie said so eloquently in the beginning. And our way of supporting you in doing that is providing the education and the support and the acknowledgement of what it is that you do, which is simply fantastic. Okay. Any last thoughts to the rest of the panel?
Comment from the floor.
Yes.
Our enrollments, because we have patients saying we do reporting application. But thank you again for everybody online and what everybody's doing. It is amazing work, and it really is important.
Thanks very much for sharing that. I think that's an obvious thing that we're dealing with at the grocery store, but it isn't as obvious that we deal with it at work too. Okay, there will be more about this, so please keep those cards and letters and ideas coming. I also want to encourage you to attend the open forum this afternoon and the presentation of the advanced practice providers. It's sure to be very interesting. And we hope to see you in October. Please travel safely. Please be well.